So now it's my great pleasure to introduce Dr. Lindsey Rearigh. Dr. Rearigh is the latest addition to a stellar infectious disease department here at McFarland and Mary Greeley. She completed her fellowship at the University of Nebraska and has been on the staff here since November of 2020, and she has kindly accepted our invitation today to shower us with some ID pearls. And please join me in welcoming Dr. Lindsey Rearigh.
Okay. Hello, everyone. I'm Dr. Lindsey Rearigh. This is what my face looks like sans mask, if I haven't met some of you guys without a mask yet, so just kind of given COVID times. I'm going to be talking to you about ID pearls today, which is kind of a broad topic, so I figured I'd just kind of cover maybe some updates on some non-COVID topics that maybe we haven't touched on in a while. I have no disclosures. And here are the objectives. I think you guys got them in the email that was sent out earlier this week, so I won't go over them. So let's get into it. Growing concerns for antimicrobial resistance. It's real and it's here. Since 2015, the World Health Organization has consistently listed antimicrobial resistance as their top 10 biggest threats. It affects food security, development, and global health. Really, it affects anyone and everyone, including those who don't even consume antimicrobials themselves. It occurs naturally, but the increasing misuse of antimicrobials in humans and animals alike is rapidly accelerating the process. A growing number of infections are actually becoming harder to treat because of this. Like pneumonia, we can't use azithromycin anymore as monotherapy. It's less effective. TB is becoming rifampin and isoniazid resistant. Gonorrhea is actually multi-drug resistant at this point. There's strains that are resistant to penicillin, doxycycline, and fluoroquinolons, so that's pretty alarming as well. Overall, antibiotic resistance leads to longer hospital stays, higher medical costs, and increased mortality. According to the CDC, about 2.8 million antibiotic-resistant infections occur in the United States each year, which cost over $4.6 billion to treat. In 1 year, there is attributed 35,000 deaths as a direct result from these infections, which, to put that into comparison, this week, the New York Times recorded 40,000 deaths to people a year who die in car accidents. So we have lots of laws and regulations to try and prevent car accident deaths, so it seems like we could do a little bit more to try and prevent deaths from bacterial resistance as well. This is a really nice chart that a pharmacist friend of mine made. It's really just an excellent summary that shows the main drug classes across the top, and it demonstrates how really there's no class of antibiotics that's not touched by some sort of resistance mechanism. And really, as you get down towards the bottom of the chart, you can see that there's some resistance mechanisms that cut across every single class as well. And really, it does happen to anyone, anywhere, even here in Ames. We're lucky to have low resistance rates overall, and no recent outbreaks like carbapenem resistance pathogens, knock on wood. But we do have some problems. These are strains from patients that I've seen in the clinic. Some resistant Pseudomonas that are a little scary, a Klebsiella in there, another Pseudomonas, and this is a Proteus that was particularly difficult to treat as well. Every extra antibiotic day actually really can cause harm as well. We've seen increasing risks of C. diff as an adverse event of extra antibiotic days. You can see an increasing risk of C. diff of about 9% per day. Also, extra antibiotic days have shown to have an increased risk of penicillin resistance in strep pneumo if beta-lactams are used. And I think most surprising and really alarming is an increased risk of pseudomonal treatment resistance of about 4% per day. In one study in particular, they recorded an increased resistance to meropenem, Zosyn, and cefepime that started just 3 days into treatment and lasted at least 60 days post-treatment, and sometimes was recorded even longer. The 9% average is just a relative risk of C. diff per day. In general, different antibiotics will give you different risks for C. diff. And in general, the broader the antibiotic class, like carbapenems, third generation cephalosporins, the higher your risk of C. diff will be. And when you get down to more narrow classes, like first-generation cephalosporins, that's going to be like your Keflex and penicillins alone, your risk of C. diff will go down. So another good reason to narrow your spectrum of antibiotic usage to cover what you know is growing or what you think the actual problem is. So how can we help? It's really about matching the right drug to the right bug for the right amount of time, with an overall trend towards shorter is better. There have been some updated guidelines that have gotten overshadowed, I think, by COVID, and I think it's time to kind of review some of those now. So let's start with pneumonia. The American Thoracic Society recently released updated guidelines for CAP. The first immediate implication is the HCAP definition is gone for good. IDSA had previously gone away with this term in 2016 with the HAP-VAP guidelines. HCAP previously defined a patient population that had any one of the following risk factors: residence in a nursing home or a long-term care facility, hospitalization for greater than 2 days within the last 90 days, home infusion therapy, chronic dialysis, or a family member with known antibiotic-resistant pathogens. If you had one of these risk factors, you previously were in a category that would automatically get you coverage for MRSA and Pseudomonas for HCAP. But in these new guidelines, clinicians are now recommended to only cover for MRSA or Pseudomonas in adults with CAP only if risk factors for either are present, with the only strongest, most consistent risk factor being if they've previously had a lower respiratory tract infection with either pathogen. Traditionally, bugs that had previously accounted for CAP had been included like strep pneumoniae, Haemophilus, Mycoplasma, Staph, Legionella, Chlamydia, Moraxella. But more recently, with the implementation of vaccinations, viral pathogens are thought to be more prominent. Strep pneumonia is still thought to be a major contributor, but it has declined significantly. In most recent studies, it went from 90 to 95% responsible down to 5 to 15%. Other main updates include recommendations for sputum and blood cultures, procalcitonin testing, and treatment options. Obtaining sputum and blood cultures are no longer routinely recommended for outpatient or inpatient setting, only if you have a severe case of CAP, and that would mean admission to the ICU and intubation. Or we would want to obtain those cultures if the patient is being empirically treated for MRSA or Pseudomonas, and that'll help us de-escalate those antibiotics in a few days. Overall, treatment has not significantly changed except for the de-emphasis on azithromycin monotherapy, particularly in areas where macrolide resistance is greater than 25%, which is pretty much everywhere within the United States, including Ames, so don't use azithromycin monotherapy. 5 days of therapy is recommended to be adequate, given the patient has reached clinical stability, which would include normal vital signs, they're eating and drinking, and they've returned to their baseline mentation. So a little bit more on therapy. Outpatient is divided into two groups: patients with comorbidities and without comorbidities. Without comorbidities, you really have two options, either amoxicillin or doxycycline. It does list macrolides as an option, but again, only if your resistance rate is less than 25%, which it's not in Ames. And then if they do have comorbidities, you can use Augmentin or a cephalosporin plus a macrolide, or you can use Augmentin or a cephalosporin plus doxycycline, or a respiratory fluoroquinolone by itself. Inpatient is divided into two categories as well, except for its severe patients and non-severe patients. Non-severe patients is a little bit similar to the second category of outpatient, with the consideration for adding MRSA or pseudomonal coverage if the correct risk factors are present. In severe, you would use a beta-lactam plus a macrolide or a beta-lactam plus a fluoroquinolone, with the consideration for adding MRSA or Pseudomonal coverage as well. Continued from these guidelines includes the fact that aspiration pneumonia is no longer automatically required to have anaerobic coverage. In general, gram-negative pathogens have not been found to be predominant, or have now been found to be predominant in aspiration pneumonia. It's really only in abscess formation that anaerobes have been found to be prevalent, and even at that, they're only seen about 20 to 30% of the time. When abscesses are not present, anaerobes were only isolated less than 1% of the time. In general, aspiration without systemic symptoms like fever, sputum production, hypoxia, does not typically require treatment, and it can be treated supportively like aspiration pneumonitis. Total duration is still around 5 to 7 days, but it would be longer if abscess or empyema were to be present. This is also supported by a recent article that was published in Chest in January of this year that demonstrated that there is no difference in anaerobic infections in severe aspirational CAP versus CAP, making the move to finalize removing anaerobic coverage recommendations from aspiration pneumonia outside of an abscess. So what to look out for upcoming in pneumonia? More and more studies are coming out pushing the boundary for shorter is better. This was a French study that came out just in March of this year, and it looked at 3 days of beta-lactam therapy versus 8 days of therapy in patients who demonstrated clinical stability at day 3. It was a pretty good study. It was blinded and randomized, and those patients who were in the 3-day group received a placebo for the rest of the 5 days. And it showed that the 3-day group was non-inferior to the 8-day group at cure rates at day 15, recurrence rates at day 30, and overall mortality. So what does this mean? 3 days seems really short to me. And I don't know if that's something that I'll immediately institute into my practice, but I think if anything, it makes me feel better and more comfortable about a 5-day regimen, because at least 5 days is longer than 3. So, okay, moving on to the GU system. 2019, IDSA updated guidelines on asymptomatic bacteriuria and really made it simple to remember who we should be screening and who we should be treating for asymptomatic bacteriuria. 1 is pregnant women. That still hasn't changed. 2 is renal transplant recipients within the first month of receiving their graft. These guidelines also really put an emphasis on care assessment of the elderly and impaired that may be coming from long-term living facilities. A lot of times, episodes of confusion, encephalopathy will be blamed on bacteriuria, but it's important to remember that antibiotics can have higher side effects on this group of patients. So if they don't have systemic symptoms like fever, suprapubic pain, flank pain, things like that, something else may be going on, and antibiotics may be avoided altogether. Another emphasis on this guideline was a recommendation to not screen patients at the end of treatment for acute UTIs, presuming that the patient is now improved. Repeat screening could lead to longer, unnecessary courses of antibiotics and possible side effects. This recommendation was also supported by the 2019 guidelines from the American Urological Association as well. Treatment, again, has been trending down in total days of duration. Men and women will still differ and also depends on which antibiotic you're using. Women, typically, you could get away with 5 days of total treatment, but if you're using a fluoroquinolone, multiple studies have now shown that 3 days is adequate. Not a lot of studies in men. Previously, all men with a UTI have been categorized as complicated UTI, but now thinking that if signs and symptoms are consistent with simple cystitis, with no pyelonephritis or prostatitis, then a shorter course is acceptable. Typically 7 days total would be adequate, but could be less if a fluoroquinolone agent is used. It is a little hard to parse out what is prostatitis versus simple cystitis because symptoms can sometimes be similar, like dysuria, hesitancy, dribbling. But prostatitis can also include pain in the penis and testicles that can radiate to the low back, mimic muscle spasms, or pyelonephritis. Also can sometimes include painful ejaculation, erectile dysfunction, as well as blood in the semen. Digital rectal exam is a really important part of the physical exam if prostatitis is suspected. And another clue to prostatitis can be initial improvement with treatment of acute UTI, but then return or worsening of symptoms once you're off antibiotic therapy and urine culture grows the same pathogen multiple times. First-line agents really haven't changed. Nitrofurantoin is still there, TMP-SMX, and fostamycin. And keeping in mind that fostamycin is still just a single-dose regimen. Okay, what's on the horizon here is decreasing duration for pyelonephritis. There's a lot of studies that have come out over the last 5 or 6 years comparing different durations from the standard 14-day timeline. This is for uncomplicated pyelonephritis, so no stones or stents or anything like that. In general, if using a fluoroquinolon, shorter durations of 7 days, even as low as 5 days, have been shown to be effective. If using a beta-lactam therapy or Bactrim, typically around 10 days with clinical improvement would be appropriate. The main focus would be on antibiotic choice, making sure that it matches up with the bacteria that is growing and has an acceptable susceptibility, or else the infection is likely to return no matter how long you treat them for. Okay, moving on to skin and soft tissue infections. I myself really have a hard time sometimes with cellulitis because I think it can be unsatisfying to treat. Erythema can be really slow to fade. Patients can be really unhappy with how slowly they feel like they're improving. But I think it's really important to know and let your patients know that a lot of times the erythema can outlast your antibiotic therapy. As long as the skin is not warm anymore, your edema is improving, they don't have any more systemic symptoms, you probably killed the pathogen there. They probably are no longer acutely infected. They just need some more time to heal the inflammation that's kind of stretched out their skin in that area. There's 2 pretty well-known trials called Establish 1 and Establish 2, which essentially established that shorter courses of antibiotics for cellulitis was okay. This gets a little confusing because it compares tedezolide to linezolid, and I feel like when I say this, just try and hang with me because it gets a little confusing. So, the part 1 of this trial showed that oral tedezolide was non-inferior to treatment of cellulitis as linezolid. And then part 2 demonstrated that 6 days of tedezolide was non-inferior to 10 days of linezolid. They judged this by treatment day cure by 48 hours to 72 hours, temperature of the skin, and then rate of recurrence, all which was non-inferior at the shorter group compared to the longer group. So this is pretty good evidence, I think, that shorter is better here, but it's a little hard to put into clinical practice because I don't think we use linezolid much. Tedezolide is not a medication that we use very much at all. Linezolid has a really high side effect profile with cytopenias. It also has a really high bioavailability, so some people say that this would be a factor in the effectiveness in this trial, so it's really hard to translate this into clinical practice. So I have some more evidence for you. This trial looked at 6 days versus 12 days again, but it used the same medication, IV fluoxacillin. So this is a narrow spectrum beta-lactam in the penicillin class. So it's similar to the penicillins that we use, like oxacillin, nafcillin, things like that. It included 248 patients, which were randomized, double-blinded, with the primary outcome including cure rate by day 14, recurrence rate by day 28, and recurrence rate by day 90. Basically, it showed that initial cure rate and recurrence rates by day 28 were the same in both groups. It did show that recurrence by day 90 was actually higher in the shorter group at 24% versus 6% in the 12-day group. All right, I know what you're saying. Why would you put this on here if you're trying to prove that shorter is better? Honestly, I don't know what this means because if you look at the study, you'll see that the shorter group was actually made up of people who had more history of previous cellulitis and had a significantly higher BMI. So this would have affected their chances of recurrent cellulitis within any time frame, no matter what their treatment length would have been. So I think we really have to split the difference here, and I think that it means that if your patient is more at risk for antibiotic side effects, deleterious effects of long hospitalizations, a shorter course of antibiotics is probably adequate. If a patient is at high risk for recurrence, you could err on the side of a little bit longer. Okay, moving on to a more specialized population. Typically immunosuppressed or by chemotherapy or other immunomodulatory therapy, febrile neutropenia is becoming more and more common. Current guidelines are all over the place on how to de-escalate broad-spectrum antimicrobial therapy once started for febrile neutropenia. Most of these guidelines are actually in need of an update. As you can see, some are as old as 2019. They undulate between continuing broad-spectrum antibiotic until ANC recovery, which in some cases could be weeks to months, or they consider transition to oral fluoroquinolon prophylaxis if fever-free for at least 48 hours with clinical stability irrespective of ANC. And more studies are supporting this second course. There's 4 studies here that were all published within the last couple of years that support the early de-escalation of broad-spectrum antibiotics even if the ANC remains below 500. Here, all these studies support that if the patient is stable, fever-free for 48 hours, there's no difference in mortality, fever recurrence, new infections, but they do have a much lower duration of broad-spectrum antibiotics and much lower side effects, including C. diff. Okay, moving away from diagnosis-specific discussion to focusing on treatment options. So let's talk about when it's appropriate to skip the IV therapy at discharge and how we can avoid fluoroquinolone overuse. Fluoroquinolones are a really love-hate relationship. You love them when you need an oral option on discharge, but you hate to use them because of their side effects. They also easily develop resistance, particularly to gram-negative pathogens. They have one of the highest risks of C. diff of any oral antibiotic out there. Not to mention, they come with a slew of FDA warnings that seem to be increasing every year. Tendinitis and rupture, I think everyone knows. Also peripheral neuropathy, that's more of a new one. It's irreversible in some of the cases that have been reported. Hypoglycemia and coma. And I think probably the most feared one would be the aortic aneurysms. So I've really touched on this a few times already, but the choice of antibiotic is often key to the total duration of the treatment. And a lot of that has to do with bioavailability. In other words, what is the uptake in the body? Is it getting to therapeutic levels at the organ that I'm treating? Is oral as good as IV? There are some orals that actually have equivalent uptake in their oral solution as their IV does, and fluoroquinolones is one of them, which makes them a popular option when transitioning from IV on discharge. But we actually have some other good options as well, including Bactrim, doxycycline, you can see linezolids on there, metronidazole, rifampin, fluconazole. I almost didn't list it, but clindamycin's also on there, but I also don't like clindamycin, so don't use it. And, you know, it's important to remember those other ones because fluoroquinolones are not the only ones. But what about these other antibiotics? Different beta-lactams, which had previously been shunned due to fears of treatment failure, may actually be pretty good choices with a more favorable side effect profile. So bioavailability, does it matter? Yes, but it's really only one piece of the puzzle. Dose is important, but some bioavailability can actually be overcome with higher and more frequent dosing, which maximizes their pharmacokinetic profile and therefore increases their efficacy, which is really important when it comes to beta-lactams. So at the right dose, they can be an appropriate alternative to fluoroquinolones, which is exactly what this study demonstrates. Looking specifically at gram-negative bacteremia from a suspected urinary source, which I know you guys know is quite common. I know you guys have all seen it. This study included over 4,000 adults from 114 different institutions and compared infections from a urinary source due to E. coli, Proteus, or Klebsiella, and that was to help decrease confounding findings. The main goal was to see if switch to oral beta-lactam therapy versus switch from fluoroquinolone or Bactrim therapy was non-inferior. Most patients received about 4 days of IV antibiotics prior to switching to orals. Beta-lactams that were used included Augmentin, Keflex, cefpodoxime, amoxicillin, ceftonir, ampicillin, cefixime. Looking at recurrent bacteremia rates and mortality, there was no significant difference between the two groups, leading to the conclusion that oral beta-lactams are a reasonable option to switch to on discharge for gram-negative bacteremia. Okay, so one last topic I was going to touch on. I think we're doing okay on time. So penicillin allergies. It's really more of a pet peeve than anything, but I just figured we could go over it. About 10% of the population reports a penicillin allergy, 10%, but less than 1% are actually truly allergic. So what constitutes a real penicillin allergy? Well, what I'm looking for is really a type 1 IgE-mediated reaction, which would typically occur immediately or within an hour, and it would constitute as anaphylaxis. So just as a reminder, anaphylaxis requires signs or symptoms of at least 2 of the following systems. So it would be skin, which would be like hives, flushing, itching, angioedema. Respiratory system, which would be cough, shortness of breath, wheezing, throat closure. Cardiovascular would be like hypertension, faintness, tachycardia, chest pain, or GI, which would be like nausea, vomiting, diarrhea. Unfortunately, patients are incorrectly labeled as penicillin allergic all the time, and broad-spectrum antibiotics are often used as an alternative to narrow-spectrum penicillins because of a labeled allergy, which can result in inappropriate or incomplete treatment regimens and possibly increase incidence of side effects and antibiotic resistance. A huge effect of listed penicillin allergy is inability or avoidance of using cefazolin as a preoperative antibiotic of choice. Cefazolin is the safest, most effective pre-op antibiotic to prevent surgical site infections. Surgeons love it because it keeps their post-op infection numbers low. Anesthesiologists love it because it's fast, easy to give, and often does not require redosing in the OR. Clindamycin and vancomycin are typically used as second-line options, but they do have higher rates of side effects and higher rates of surgical site infections recorded. So that's why I love this study. This just came out in March of this year. It is a review and meta-analysis that included over 6,000 surgical patients that had been labeled with a penicillin allergy, but who had also been tested for cefazolin tolerability. And it came to the dramatic conclusion that there was only 0.7% of patients that had a true cefazolin reaction. 0.7%, with 10% of the population reporting a penicillin allergy and 0.7% reporting a reaction to cefazolin. That's just great. This also showed that overall self-reporting of penicillin allergy was high, with only 0.6 confirming a true allergy. Self-reporting of cefazolin was lower, but the higher percentage of confirmed reactions at 3%. Meaning most patients with a penicillin allergy history would be safe to receive cefazolin. And then, fortunately, just when I was making this PowerPoint, there was a follow-up study to this that was published just this month. There was a retrospective study that looked at surgical patients that were labeled as penicillin allergic and had received either cefazolin, clindamycin, or vancomycin preoperatively. It looked at the hypersensitivity reactions experienced between each group. It included 690 patients total. There was 15 that experienced an immediate hypersensitivity reaction and 7 with a possible hypersensitivity reaction. And you can see that in each group, there was about 1% in each antibiotic class with each reaction. And there was no significant difference between the groups. So this demonstrated that overall perioperative hypersensitivity reactions are uncommon in patients labeled as penicillin allergic. And reaction to cefazolin is not higher than other antibiotics used as second line. So maybe next time we'll consider picking the cefazolin. Okay, so all that being said, I think you're probably asking yourself, okay, I got all the information I need, so when do I need to consult ID? I mean, I think at the end of the day, infections are hard. I mean, infections are hard for me. I think infections are hard for Dr. Fulton. We talk about them all the time. But I think, if you are ever uncomfortable, please feel free to reach out to us. Not all these patients that we see are going to fit into the guidelines. Not all of these patients that we see are even going to have an even number of days of antibiotics that we can prescribe to them. They're not all going to be the 10, 14 days, Definitely consider us for any patient that has multiple organs involved in their infections or any prosthetic material that may be infected. Definitely patients with history of multi-drug resistant pathogens, as we may be able to have different options or ideas about how to treat them. And definitely any patients discharging on IV therapy, as we can help monitor for drug toxicities and any other complications that may occur and infection recurrence. And that's all I have for you guys. So I think we left enough time for questions, which I think they're bringing up now. Blood cultures are required for potential sepsis cases per CMS measure. What are your recommendations regarding this? I see that they are not necessarily recommended routinely for pneumonia now. Yeah, and sepsis is just a collection of vital signs, so if you think that your patient, that is not meeting those sepsis criteria, I don't think we necessarily have to get those blood cultures if we think that it's just, like a routine pneumonia. I know it's kind of hard, especially evaluating in the ERs, particularly right away. They're usually tachycardic just because they're nervous and things like that. So I guess just kind of use your best judgment. And, if you think something else is going on too, definitely get those blood cultures. So would definitely err on the side of caution in that case. Should aspiration pneumonia be on isolation? If not, why? Does it, I don't see the rest of that question. Does it need to treat with antibiotics? So if it's true, so aspiration pneumonia does not have any isolation precautions. I don't know a reason why it would have aspiration precautions. I'm actually with Emily Law with infection control, and I don't think we have any guidelines that would make them be on isolation precautions. And you would treat them for if they have a true pneumonia, like with systemic symptoms like fever, elevated white blood cell count, procalcitonin, infiltrate on x-ray, things like that. If you think that they just have aspiration pneumonitis, so like a chemical reaction from just aspiration, then you don't necessarily have to treat them with antibiotics. You could just treat them supportively. No sputum cultures for CAP, no MRSA coverage for Pseudomonas coverage unless prior infection documented. It seems it would be hard to diagnose resistant pneumonia without sputum culture. Well, the most significant clinical risk factor is previous history of lower respiratory tract infection with MRSA or Pseudomonas, and the reason that you would have a lower respiratory tract sample would be from an induced sputum sample or like a bronch or something like that. And you would have a high clinical suspicion like the patient's not getting better or they have an abscess or something like that. So if you think that they just have simple CAP though, they don't necessarily need a sputum culture. I don't know if that answers your question, Dr. Killian. I think that you could move to getting a sputum culture if they're not getting any better after a couple of days of treatment. If the patient has long-term antibiotic therapy, do they need to be on antifungal meds? Not necessarily. It really just depends on the situation. There are some guidelines, like in the setting of peritoneal dialysis, that does recommend for prevention of spontaneous fungal peritonitis, that if they are on any long-term antibiotic use, that they would be on antifungal prophylaxis, but not routinely in the normal population do people need to be on antifungal prophylaxis with long-term antibiotic use. Okay, well, I guess if you guys don't have any more questions, then we'll go ahead and wrap this up. Thanks for having me. Feel free to shoot me an email if there's anything I can follow up on or any other questions that I can answer on the side. I'd be happy to assist if I can. And thanks so much.